we shall be looking at steroid response glaucoma. With me are very wonderful ladies and doctors who are going to moderate and talk to us about it today. So without further ado, I would like to welcome Dr. Lois to introduce herself and welcome the speaker for today. Karibu, Dr. Lois. You're muted. Okay.
Good evening, everyone. Thank you so much for making time to join in today's CME. My name is Dr. Lois Mwangi. I am an ophthalmologist at PCA Kikuyu Hospital. I also teach at JKU University. I teach the medical students through ophthalmology. I'd like to extend a warm welcome to everybody who made time to join in today's CME. Our speaker today is my colleague and friend, Dr. Wanjiku. She'll be taking us through steroid-induced glaucoma. If you have any questions, please put them into the chat and we will address them at the end of this talk. Dr. Wanjiku, please welcome.
Thank you very much. Thank you, Lois. As I continue to sort out, okay, there you go. All right. Our topic for today is steroid response glaucoma. But I think I sent out the topic, sharing all my slides, because really I want us to go into just discuss steroid potency and how judicious use of steroids. I think that would have been a more appropriate title for my topic today. But still, we're going to discuss all that. So I'm sharing my slides. Can you see them?
Yes,
we can.
Can you see my slide? All right, great. So we're going to go into steroid response, not only glaucoma, but mostly increase in IOP after steroid use.
Doc, could you turn on the slideshow perhaps?
You can't see my...
We can see the slides, but they're not in, we're having everything side by side. Maybe if we can have one slide.
Okay, okay, I see what you mean.
Yes.
Is that better?
No.
Okay.
Not yet.
What?
Just from the beginning. We set up in the year from the beginning.
Wapi? Stop laughing.
Where you have the
slideshow,
then to your left, to your extreme left. Hover around. Yes, that one.
Okay. All right, so steroid response. So I'll start with a case presentation. This is a patient that I saw about 3 years ago. He came to us for purposes of further investigation in terms of OCT and his visual fields done, because he had presented to a private facility, someone's private clinic, with complaints of halos, which he had been seeing for about a month in both eyes. So when he was investigated, the IOP as per the referral letter was 32 millimeters of mercury in the right eye and 36 millimeters of mercury in the left eye. So he was started on Diamox and was put on both Lumigan and Compigan, and then the pressures at presentation had lowered markedly. So he was sent for OCT and visual field. So when he presented, so actually very important is that he had been using Probeta N for his allergies. He used to buy over the counter since he was in high school. So calculating, he was about 23 years old actually when I met him. So that was almost 10 years of using this potent steroid. So on examination, he had good vision in both eyes of 6.6. His IOP at presentation, remember he was already on anti-glaucoma medications. The right eye was at 15, the left eye was at 20. The anterior segment was normal. He actually had grade 1 RAPD in the left eye. The right eye was normal. He had open angles in both eyes. Of note is that he had CDR of 0.5 in the right eye, but 0.9 in the left eye that also had a notch. So actually on the visual field, there was no, despite the high eye pressures that were noted in both eyes, the left eye did not have any damage on both OCT and visual field, but the left eye continued to progress. So I really don't want us to go into the visual fields and the OCT of these patients. I want us to talk about some of the challenges that we faced with this patient. One of his greatest complaints was that his eyes were always red. And so he kept going to the steroids because his eyes would become a bit less inflamed when he was on the steroid. So it was not only the itching, but also the redness. So after treating him, even on the putting him on antihistamines for his allergies and the glaucoma medication, his eyes continued to be markedly red. And at some point, we asked ourselves, could he be reacting to the BAK? And for sure, when we switched him to anti-glaucoma medications that were BAK free, his eyes cleared. And for the first time since I started treating the patient, which was about 6 months in, took us a while to figure out this patient might be reacting to the BAK. For the first time since I started seeing that patient, his eyes were not looking like he was smoking something or was, you know, the red, he used to look like he was angry at me. So for once, he was looking, his eyes were looking quite clear. Another challenge that I faced with this patient was that at the age of 23, he was under his mother's insurance cover, and that elapses at the age of 24. So he had insurance, but getting money to pay for the consultations and also for the drugs, because remember the BAK-free anti-glaucoma medications, they're not cheap. They're about 2,000 Kenya shillings. So every month he had to look for 2,000, and he was a student. He was an aviation student. And that was challenge number 3, that one eye actually had tunnel vision, and therefore he could not have the good 3D vision that would help him in his career. So in fact, he eventually became a farmer. Number 3 is that because he was not able to continue buying the drops that were BAK free, we opted and tried to get him to do SLT to try and see if we can stop using medications. Because actually over time, we tapered off the medications. The right eye really responded quite well, but the left eye, which was already the problematic eye, continued to have high IOPs. And of course, because of the different CDRs, the target IOP for the left eye was much lower than that of the left eye. So at 15, the left eye was quite okay, but for the left eye, we wanted pressures lower than 13. But they never came down to below 15, even on maximum medication. And remember, cash was an issue. So we did SLT, but again, back to the same problem that after SLT, this patient needed a steroid. The SLT will cause a bit of inflammation. He was put on steroids again. And the damage after the SLT, you could see there was a change in the notch had become bigger after the SLT. Another problem arose after about a year since I started seeing the patient. The same eye, this eye, I felt like was under attack. The same eye developed a cataract. Right eye all through remained okay. Same eye developed cataract. What do we do in cataracts? We go in, we cause inflammation, again, post-op steroid use. I can tell you by the end of all this, within about 2 years, we are left with tunnel vision that was much smaller than when we started. We really struggled with this case and with this patient. Eventually, he ended up saying, I can't afford these medications. We've done the best we can, leave my eye alone. I'll go into farming. So he's been doing farming. I've been following him up. His pressures in that eye have been about 15. We still have the tunnel vision, thankfully. And that is what we are going to discuss today. So steroid, what is steroid response? Steroid response is defined as an increase in IOP of more than 5 millimeters of mercury from the baseline, or an IOP of more than 24 millimeters of mercury in a patient after you started steroid and there was no history of glaucoma. So it's usually noted a few weeks after starting the steroids, usually with topical steroids. However, of course, if we're talking about intravitreals, then you'll notice it's a few hours after the injection, the intravitreals. Also, if you're using particularly potent steroids or high dose steroids, intravitreal steroids, then you might note the increase in IOP a few hours after. But usually, when we're talking about topical, the drops or subtenon and subconj, we'll notice a few weeks after. This is important because we're going to talk about it and as we talk about how we work together with steroids. So about a fifth of patients who are started on steroids will develop steroid response. So it's more common than we appreciate. But lucky for us, most patients, once we stop the steroids, about 2 to 4 weeks after the withdrawal of the steroids, then they go back to their normal IOPs. However, of note, the ones we are concerned about are the 1 to 5% who convert to primary open angle glaucoma. So this is a small percentage. However, considering how much we use steroids in our practice, this might actually end up being quite a large number. So we can't avoid steroids. We really can't avoid steroids. I mean, we see some allergies that are ridiculous. Those huge papillae, and then you have conjunctive limbo stem cell deficiency, and the conjunctiva starts to creep onto the visual axis. And really, what do? We have some large cobblestones that require injection of steroids. You have uveitis. We have a lot of uveitis. I mean, there are so many indications for steroids. So the purpose of the talk today is not to discourage us from using steroids, is how are we going to work with these steroids so that we don't end up causing damage, we do no harm, which is the oath that we took. So part of risk assessment is knowing which type of steroid and which route carries a higher risk. So ocular route carries higher risk of increase in IOP as compared to systemic use of steroids. So let me first deal with the systemic, that it is rare, but a few cases have been reported. And this is most likely because of the blood ocular barrier, which prevents from too much entry of the steroids into the eye. So the ocular route, I've arranged them in accordance in the intravitreal route has higher likelihood of causing an increase in IOP as compared to the other. So intravitreal, you have higher risk of steroid response, of raising ocular pressure, as opposed to periocular injections, which is subtenon or subconjunctival. And then least is topical. Now, intravitreal, I've written there, triamcinolone, you have the Ozurdex, and you have the Retisert. These are different types of steroids, which we'll come to discuss on the next slide, that it's very important, even the type of steroid and the strength of steroid that you use. So triamcinolone, about 50% of patients after injection of triamcinolone have been found to have an increase of more than 24 millimeters of mercury. So most of them will respond quite well to an anti-glaucoma medication. Now, Ozurdex is a dexamethasone. So now we are comparing between different types of steroids. Ozurdex also lasts longer than the triamcinolone. Ozurdex will last you about 6 months, triamcinolone about 3 months. So that also comes into play. The dexamethasone itself is a moderate to high potency steroid, and that will cause also about 50 to 60% increase so 50–60% of patients after the insertion of the Ozurdex will have increase in their IOP. By increase, I mean a significant increase in their IOP, which we mentioned to be more than 24 millimeters of mercury, figures that required intervention in terms of most patients will need to be put on anti-glaucoma medications, and some even went as far as to require surgical intervention. The last one is Retisat versus Iluvien. Both are fluocinolone intravitreal injections and of different strengths. So the strength of the steroid, even when it is the same steroid, actually makes a difference. And that we'll discuss also on the next slide. So intravitreal ocular use of steroids carries the highest risk of causing increase in intraocular pressure. So periocular injection is next. So that's our subtenon and subconj steroid injections. And then finally, that's the topical, that's the drops that we use, or sometimes the ointments. So let's talk about this potency. So potency is attached to penetration into the aqueous humor. So what is measured when we talk about the potency of a steroid is how much protein did we find in the aqueous humor when we used this drop. Okay, so some steroids may be said to not be potent, but they work quite well on the surface. And that's our fluorometholone and our hydrocortisone mostly. So they do quite well with surface inflammation, but they don't do as well in the intraocular inflammations. That's what we mean by potency. So penetration into the aqueous humor, the salts that it is paired with, you find that sometimes you have, let's say prednisolone. Prednisolone, you have the prednisolone acetate versus the prednisolone phosphate. So the acetate is more potent than the phosphate. So the salt it is paired with really does matter. The strength of the steroid. Now, I'll keep referring to the prednisolone. There's a prednisolone 40, which is prednisolone 1%, as opposed to your normal prednisolone, which should be about 0.1% or less, anything less than 1%. So that is less potent than your prednisolone 1. And therefore, the strength of the steroid in terms of the percentage actually can increase your risk of having increase in IOP. So therefore, to me, the lesson was to read, to not just say, what do I think to myself? Maybe this is Tobradex. So I concluded this is a dexamethasone, and therefore that dexamethasone is a moderate strength, is a moderate potency steroid, and therefore I can take that risk. If I've not looked at the percentage of the steroid, then I've not completed my analysis of the risk versus benefit for that patient. So as I've written there, it directly linked to the likelihood of increase in IOP and other intraocular complications. We mentioned about cataracts, and there are other complications of steroids in the eye. So this is for the most commonly used percentages and strengths of steroid that we have in the market. So low potency is your fluorometholone. It hardly penetrates into the eye and therefore is good for ocular surface inflammations. Moderate potency, prednisolone, but as I've said, you have to consider the strength of the steroid of your formulation. You also have to take into consideration the salt that it is paired with. We have prednisolone acetate, prednisolone phosphate. Dexamethasone 1% is not the same as dexamethasone 0.1%. A study that was done shows the dexamethasone 0.1% has higher increase in IOP than 0.01%, which kind of makes sense. But then if we don't look at the medications that we're giving our patients, then we will not be able to use our steroids judiciously. Betamethasone, this came as a surprise to me, is also a moderate potency drug. The high potency drug, I try to look at which medications we have available in the market that I have encountered. However, if there's any that you feel should have been added here and is available in our market, please feel free to educate us. Difluprednate. I always thought Optipred is a prednisolone, but it's a difluprednate, and it's high potency and actually causes higher IOPs than the betamethasone, prednisolone, and dexamethasone. And therefore, you might want that high potency in some instances. For example, if you have a uveitis, you want that increased potency, but therefore you also need to be more careful with the IOP checks, as opposed to perhaps if you want to make use of this medication in terms of post-op, then this might not be the best post-op medication. This is what I mean by judicious use of your steroids. As we have said, we cannot avoid steroids. Steroids are our friends and sometimes they are our enemies. So what do? One, we must check IOPs prior to start or before we start use of steroids. So many times that we use steroids and sometimes our clinics are so busy. However, the point of today's presentation is to remind us that up to a fifth of the patients that we see will develop steroid response. And then up to 5% of those patients will develop primary open angle glaucoma. And we don't want that to be on us. If you must use your steroids, use them appropriately. There's something I remember Dr. Gishui said long ago and it stuck with me. Uveitis must be treated, you hit it hard and hit it fast, and you use it for the appropriate length of time. So we're not saying don't use steroids or use them for a short period of time and run away from them. No, if you're treating uveitis, that is the immediate threat. But knowing that steroids have these other complications, how do you then follow up this patient? You must check IOPs regularly, every 2 weeks if the patient does not have a history or family history or personal history of steroid response or open angle glaucoma or closed angle glaucoma for that matter. Then you can follow up every 2 weeks, check the pressures. And then taper down once the uveitis has started to respond and there are no cells. Do not tolerate flare or cells. You would rather, as you're checking your pressures, then still put them on the anti-glaucoma medications, so that once you are ready to start tapering down, taper down judiciously and continue monitoring the IOPs. If they're not responding, then you know how to act, rather than if you stop the steroids too soon, then you have refractory uveitis, then you put them back again on steroids, you end up risking the patient for a much longer period, rather than if you had done the right thing at the right time. So we're not saying don't use the steroids, we're saying use them wisely and continue monitoring, be aware of the risks involved. So weekly review if the patient has had previous steroids response or is a glaucoma patient. I had a patient who had young patient, about 25 years old, which already makes me even more anxious to put her on a steroid. But she had this conjunctivitis that just refused to respond to the NSAIDs. And she came back and said, can we try a steroid? And I was very hesitant to put her on a steroid, but her eyes looked red, and this is a lady, so she was feeling very self-conscious. So I put her on fluorometholone for a short period of time, followed her within 3 days. There was good decrease in the injection of the conjunctiva, extended for another 3 weeks, kept checking the pressures, and then quickly, once the eyes started responding to the anti-inflammatory, then started about every 3 days, reducing the frequency of the fluorometholone. The pressures never spiked. However, it was important to keep checking and reassuring the patient, this is why I'm seeing you so frequently, because these are the risks involved. If I see this, this is what we're going to do. just because this patient was already a glaucoma patient, she was not on any medication. She had trabeculectomy in both eyes. And also the injection over the conjunctiva was a risk to the trabeculectomy. Then I was forced to, because it was not responding, to put her on that weak, low potency steroid, and that worked for that patient. Another tip and trick would be to consider tapering down to lower potency steroid. Say post-op, you felt the need to, I remember Dr. Khan used to insist, a mono eye patient, post-op, you give prednisolone. A child also, because of you expect inflammation, you start on a high potency or moderate potency steroid post-op. So if you find within the first 1 to 2 weeks, you've not had the fibrin or the inflammation that you expected, then may we consider using a lower potency in terms of strength, could be in terms of strength, could be in terms of the type of steroid. We taper down using a lower potency steroid, because again, we have the issue of, if we stop suddenly, you have rebound inflammation. For long-term use, these are our PKP patients who might be on steroids for anywhere from 6 months to 1.5 years. And this is very important. Again, we can't avoid, we can't not put these patients on steroids. However, I actually also have a patient who, every time he stops his anti-allergy medications, the inflammation comes back, and he has such bad limbal stem cell deficiency, he only has a small clear island of cornea right in the middle. Terrible candidate for PKP, but he still has almost 6 vision. So this is a patient who I have put on tacrolimus ointment, and I would want for this to be a bit more available, or other forms of DMARDs. Instead of putting the patient on long-term steroids, DMARDs are safer and don't have these complications that steroids have. And that was what I had for us for today. I think I welcome any questions or comments.
Thank you, Dr. Wanjiku. We have 2 questions in the chat. I'll table them to you, and then you can respond, or maybe call on to the audience for people to contribute. So Dr. Wendy is asking, how much experience do we have with tacrolimus eye ointment for ocular allergy? Do you want to respond to that?
Yes, I do. I saw a study where they used tacrolimus for up to 5 years in a patient, in the morning and in the evening, which was the beautiful thing about that ointment. The caution, however, was to not put it inside the eye, because many patients complained about burning, but put on the lids. It helped even with the discoloration on the lids, and so which patients are very happy about, and reduced the inflammation and need for steroids. So they used for up to 5 years, and it was quite safe.
Maybe
but
to follow up
we don't have much experience. Yeah.
Maybe to follow up that question is what strength, what percentage of tacrolimus? Because I know there's a 0.01 and there's a 0.03%. Which one is recommended for ocular use?
I think the one we have is 0.03%, the one that I've seen in our market. And that's I have used it, and minimal complaints, except the ones who put in their eyes and they report burning. Yeah.
Okay, so we put on the lids.
Mm-hmm.
Okay. Anyone else with a question with regard to tacrolimus? Okay, we move on to Dr. Mark Nganga's question. He says, thanks for the great presentation. How do we ensure chemists check IOPs for of all patients they sell steroids to, since they dispense even without prescription?
Thank you. I will direct this question to Dr. Gishangi if he is here. Is he? This is a great question because we have a huge fight with the Pro-Beta-N because it's very easily available. I mean, all patients that I have seen who have a ridiculous infection that has been worsened by a steroid, it is usually Pro-Beta-N. Every cataract that I have seen in a young patient because of prolonged steroid use, it is because of Pro-Beta-N, because it is so easily available, and that's the first thing. Macho yako ni red, shika hii. That's the one that they
it's
are
also
all
quite cheap because it's
it is
100
so
bob.
ridiculously cheap. Yeah, so
we don't seem to have Dr. Gishangi in the CME. I don't know. Mark, I don't know who will respond to your question.
It's not me.
Anybody else with a question?
I can see one from Dr.
There's another one for the chat.
Okay. Yeah, it's not showing on my side. From who? I can't see. Kalu, could you?
There's a question from Patrick Nyaga. In your experience or estimation, what proportion of patients get glaucoma from steroids bought over the counter compared to those with prescription steroids?
Well, I'll not hazard to answer in terms of proportion. I think the danger is mostly in terms of they are told over the counter, put 2 drops 3 times a day, and then there's no tapering, and then they can always come back and keep getting. For you who gives as a prescription, you will give maybe 3 days each or 5 days and taper down. And then, you know, once you're done, you stop. So it's not only the steroid, it is that even the dosage, and dose actually does increase the likelihood of having the steroid related complications. And they keep going back and getting the same medication. So that patient who gets used to buying the steroids from the chemist will not come to you next time. Maybe it's an infection, a bacterial infection, not an inflammation like they had the previous time. So if they go back, the last time it worked, but this time it's an infection, they go, I have a patient who has had a foreign body in his eye, went to the chemist, was given Pro-Beta-N. Symptoms did not improve, came now in a lot of pain because there's a foreign body. When they're used to over-the-counter medication, they keep going back and increasing the chances of coming back with the steroid-related complications. I think it's the profile of the patient. Yeah. I don't think that answers you, but.
Okay, so we have another question from Dr. Nirmal Nasaraya. So they're asking, what's the best way to measure IOP in COVID times? Shiko, do you want to respond to this? I think it's been discussed before. On how to clean the tonometer. What are we doing in our practice?
Okay, you can answer.
So we are currently still using spirit to wipe the tonometer. I know in my setup we use mostly the eye care and the applanation tonometer. We're still using spirit, but I think it's been discussed before when COVID was still very fresh in our setup. And if I remember well, the conclusion was that it was best to use GIC, the diluted GIC solution. Well, I can tell for sure in Kikuyu we are not doing that. We are using spirit swabs to swab our tonometers and our eye care. I don't know if anybody else is doing anything different. Maybe they can comment. Clearly, nobody is commenting. So, okay.
There's a
Dr.
comment.
Dr. Nandasaba is saying non-contact tonometry is useful during these COVID times for accurate measurement, Goldman stands.
Yeah, the gold standards remains the same.
Okay, I think you've been answered, Dr. Nirmal. What about non-contact tonometry? Is it helpful? Yeah, it is. If you have it, by all means, use it. So we have another comment from JN.
Hold on. I would say that use the non-contact as a way to screen, because we are saying check your patients. So if the non-contact tonometer tells you about 15 or thereabout, then you don't need to go and do, you may not need to go proceed to the to the Goldman. However, if you're getting a non-contact giving you about 23, then that is the patient that needs to go and have the confirmation with the Goldman tonometer.
Okay. There's a comment from JN. He says cyclosporine eye drops are also quite effective as steroid substitutes for allergy. And that's true. The beauty about cyclosporine is that it is also readily available as compared to something like cyclophosphamide and even the tacrolimus ointment. So if you have it, I think it's a good substitute. I agree. Any other questions? Any other comments? Is there one that I'm missing?
From Angela Mokaya, there is a comment on health promotion and education may help with the inappropriate over-the-counter purchase of eye drops. So I think that would be, the onus would be on all of us to give that health talk to patients, caregivers as they come, so that they can even spread that information to their neighbors and other family members that not to use over-the-counter medication, especially the steroid eye drops, inappropriately.
Oh yeah, that's a great point. And also even for the patients that we're putting on steroids, explaining why we are tapering down and why we are stopping after whatever period of time, and why they should not get it again over the counter unless
and why they should also sample. Yeah.
That is very true. That is very true. So that they don't say, this worked for me, I keep the bottle, next time I just go to the chemist and get it myself, rather than making the trip. Yeah, that's a great point. But we still want Probeta N blacklisted.
So I think that's the comment that Mark is making. Without proper and strict regulation of non-IOP measuring practitioners who prescribe and dispense steroids and Probeta generously, we shall soon, unfortunately, have a steroid-induced glaucoma epidemic. Yeah, that's correct, Mark. I think Dr. Gishangi should join in and tell us what he will do about it. So Dr. Walia is doing the correct thing because he uses jig solution regularly to disinfect the head and also use the toner pen with disposable tips. Wow. Okay. I hope Dr. Masila is in in our setup. So, but the CME that discussed about disinfection during COVID times really touched on disinfecting the tonometer and the tonometer heads with the jig solution. I think that was the agreeable one. It did clear the viruses and the bacteria and everything else. Yeah. Dr. Godfrey Nyaga says, should we be more aggressive in surgery for glaucoma, considering your case presentation to stop prolonged use of prolonged steroid use and BK issues? Wanjiku.
This is something I was even discussed in last Thursday during the launch, that glaucoma in the young and in Africans is so aggressive.
Yeah.
I'm actually more pro surgery, but our population, we are afraid of surgery and also not very compliant with medication. And therefore, I think on some level, it is up to the surgeon. Having said that, SLT, as this, I presented a paper recently about the efficacy of SLT, and especially in Blacks. So really, before we go to, there's a midway. We have that laser option, and perhaps to calm us down, the ones who are pro-surgery, can we at least consider SLT as an option? Yes.
Okay. I hope, Dr. Nyaga, your question is addressed adequately. Anybody else with a question before we hand over to the sponsors of the meeting?
Wait, before even I'm surprised the VRs have not commented, considering how heavily I have attacked them. And number two, I would like to hear, hopefully from the other, from Dr. Marco, Professor Kiage, something.
Okay, let me read a comment from Angela Mukaya. Says, engage the pharmaceutical companies. They may be willing to support a public health education campaign if they learned about the widely held negative sentiment on Probeta etc., though they may have conflict of interest because of the dollars. Well,
these guys don't even need any CMEs. They don't even, because they don't need us or our prescriptions.
Yeah. Any comment from Dr. Marco, Prof. Kiage, Dr. Masila?
I think Dr. Marco was in, but currently is not in, and I'm not seeing Dr. Masila or Prof. Kiage. So unless there's someone else who has a comment and they can raise their hand, I think we might have to, yes, to close with that. I'm not seeing any of them on.
Okay. So maybe, Dr. Wanjiku, you can stop sharing so that the sponsors can share their presentation. I'd kindly request all of us to hold on for a few minutes and hear what our sponsors have to tell us about their products, and then we can finish the meeting. We will finish it in good time.
Thank you, Dr. Lois. Sai Pharmaceuticals will be the sponsors for today, and Michael Munga, I think, is going to give us a word. Michael, continue.
Okay, good evening all. My name is Michael Munga, medical representative with Sai Pharmaceuticals. I'm also joined with my other colleagues. If they can just raise their hands through the app, so as to know any strange name, just know it's two or three of my colleagues. So I would like to begin by saying thank you for giving us this such wonderful opportunity. And also, as a point to note is that we really do need your prescriptions. That's why we've decided to actually join you for this educative session. We've really learned a lot, even in our practices in terms of when we go to market our products. So we really say thank you for this presentation. So to begin off, in line with the theme of today of anti-glaucoma medications, Pharmaceuticals has two preparations. One of them is Brimochek T and Zolichek T. With Brimochek T, Brimochek T contains brimonidine at 0.2% and timolol malate at 0.5%, acting synergistically to reduce the production, the amount produced of the aqueous humor, and also reduce the inflow of aqueous humor into the eye. So we may ask, why would you want to use Brimochek T? With the dual mode of action, it brings about an additive effect to bring about better IOP lowering in the patients. And because of the convenient dosing of twice a day, will bring about patients' adherence. Then we say that using our safety standards, you can be assured of quality products to your patients. This is actually a picture of what actually Brimochek T looks like. When a patient comes back with anything different, please do note it's not Brimochek T. Then the other preparation, our anti-glaucoma, is Zolichek T, a combination of dozolamide at 2% and timolol at 0.5%. For Zolichek T, this is a presentation of Zolichek T. Anything else is not Zolichek T. Also, just to mention a bit on ocular allergy, as Pharmaceuticals, we really endeavor to give a complete eye package to your patients. What we are having is a preparation for allergic conjunctivitis. Our preparation is called Allercheck. We have Allercheck in two strengths. We have Allercheck at 0.1%, which is a twice daily dosing. They also have Allercheck 0.2%, which is an once a day dosing. So why would you choose our products as Pharmaceuticals? One thing you should note is that we have a 3-piece container whereby we've talked, I've had Dr. share about cost. So our 3-piece container only allows 1 drop to come out at a time. So that what it means for your patient is that they'll get exact dosage of the medication and also reduce wastage through having the controlled release of 1 drop. So I would like to end there and also say thank you for the support that you've given us through the years. And we endeavor to continue bringing to you quality products as Pharmaceuticals. Thank you.
Okay, thank you so much, Pharmaceuticals. Does anyone have a question for Michael? Paul, your hand is raised.
And not a question, just to thank you the team for allowing us to be together with you today as we discuss about anti-glaucoma and allergy.
Okay. Okay, thank you so much for sponsoring our CME tonight. I hope every one of us have learned something. So unless we have any announcements from the OSK desk.
There is I have a few announcements. So before we come to the end of this CME today, I would like first to thank you all for being available, for availing your time and yourselves to attend and make it a success. Thank you, Dr. Wanjiku, for such a wonderful presentation on a thing that is an everyday dilemma for some, and it's good to remind ourselves and also to learn one or two new things. Thank you, Dr. Lois, for a wonderful moderation. I would like to remind us that our subscriptions for the OSK are due by 31st of this month. Please remember to pay up. With your subscription, we are able to do quite a lot for the society. So help us as we try to achieve our mandate as OSK. Also would like to inform us that we are planning another hybrid CME. This one will be courtesy of the Young Ophthalmology Forum. The date and the presenters and the topic will be communicated in due course, but prepare yourselves. For those who missed last week's hybrid and were not able to attend in person and enjoy the MLO that was prepared, this coming one, endeavor not to miss. And we will send you the save the date in good time so that you can join us, and we shall enjoy even as we learn. I would also like to inform us that we still have a few slots for CME that we have not yet picked up. So if you have a presentation, please, and you'd like to present, please get in touch with me or our administrator, Evans, and we shall be able to assist you so that you can share with us your knowledge, because I know we have vast amounts of knowledge and we all learn every day. Our next CME shall be in 2 weeks' time. Details will be communicated in due course. Yes, those are the announcements for today. Thank you very, very much for attending. Dr. Lois, our last words, parting shot.
Parting shot is pay OSK membership. Yeah. What's his name? Evans. Evans has been reminding us, and he's actually put it as the pay bill number as his WhatsApp profile photo. So let's remember to pay up so that we can keep the OSK going. And I think with that, we can end the meeting. And we look forward to having you again for the next CME. Have a good night. Thank you.
Thank you and good night.